Hi, this is Amy Ginian, and this is a Week 5 project on evidence-based practice management. My research articles were all about induction of labor, and does this contribute to the primary C-section rate? So the focus or the problem that we are researching or the gap in literature is, does the C-section rate or risk of C-section increase when a mother or a pregnant woman undergoes induction of labor? According to a position statement in 2005 from the American College of Obstetrician and Gynecologists, 23.4% increase in risk of C-section when labor is induced versus a term mother going into labor spontaneously, whether her membranes were to rupture or contractions causing cervical dilation were to occur. And why is this important? It's important because it affects the mode of delivery. Ideally, the obstetrician would want all pregnant mothers to undergo a vaginal delivery, and cesarean deliveries affect how the mothers recover, the mode of their next delivery. Typically, once you have a C-section, although you're not destined to have another C-section, the risk of having a vaginal birth after a C-section is great for uterine rupture and fetal demise. So typically the safer option would be to continue having C-sections. And C-sections do affect the way that babies transition from intrauterine to extrauterine life. They don't have the same physiological changes that occur when they are being pushed through the birth canal. But sometimes induction of labor is necessary. So obstetricians need to weigh the risks and benefits of induction of labor. And if this is truly the case, how do they correlate? So debatably, one of the largest risks of induction of labor is the subsequent necessity for the primary C-section. Over recent years, research has surfaced to show that induction, as long as the mom has a favorable cervix, does actually not increase the risk. And so practice management and findings have started to change this thought process. I found this topic interesting on a personal level because I do work in labor and delivery, and I just found it interesting to dive a little bit deeper into this topic because we do see a lot of inductions of labor, specifically at Women's and Babies where I'm currently working. And I just found it was interesting. The findings were all pretty consistent amongst the articles that I did research on. So this is just a continuation of what we were just discussing. Induction alone does not contribute to increased C-section rates. So what other factors are involved? The articles that were chosen, 3 of which are quantitative research. They analyzed data from randomized controls trials. Some of the studies are smaller, pulled from a smaller sample size, and the largest of the studies has approximately 10,000 women that are being reviewed and is currently still in process. So the independent variable would be induction of labor. The dependent variable is expected management or spontaneous labor. And the outcome is the mode of delivery, vaginal delivery, cesarean delivery. The PICO question is, in term pregnant women who present with a single live cephalic fetus, which those could be your inclusion requirements, does induction of labor contribute to cesarean section rates? P, which is the problem, pregnant women who present at term so term is 37 to 41. Singleton, so one viable fetus. And cephalic presentation. Cephalic presentation means that the baby's head is down and it's not in the breech presentation, which would automatically qualify someone for a C-section. Women are from the United States, United Kingdom, India, and Sweden, all older than 18 years of age, all provided informed consent. And the socioeconomic status of these participants was not discussed in any of the research. The I is term women undergoing induction of labor. The comparative, the C, term women entering into spontaneous labor who would undergo expectant management. And the O outcome is the mode of delivery, vaginal versus cesarean. Here is an overview of the various articles that were utilized during the course of this research. The first was on elective induction, comparative to expectant management of first-time moms at 31 weeks. Second was elective induction versus spontaneous labor, also known as this expectant management at term. And then a prospective study of the outcomes. The third is the study that is currently underway. It is being done or performed in Sweden. And it's a randomized control study to compare induction of labor at 41 completed weeks, gestation versus expectant management, and or induction at 42 completed weeks. I'm going to skip ahead and then I'll go back. The fourth is how obstetricians have been defining a failed induction of labor. One of the contributors of the primary C-section is providers will say, well, this patient had a failed induction of labor due to failure to progress, failure to dilate, fetal distress, infection, things of those nature. And lastly is a qualitative meta-analysis, which is a secondary source, reviewing abstracted charts to look if induction of labor also increases the risk of C-section. So the first article, really the first four articles all had similar findings. The first of two articles, the elective induction of labor compared with expectant management and elective induction versus spontaneous labor, both had a very similar participant size. The first was 162 women evenly split up between the two groups. And Miller et al. Showed that the two subgroups really did not have a clinically significant statistical difference. The second study, which was also a randomized controlled study, had 200 participants. This was taken place in India, and also had similar findings where it did not show a clinically statistical significant difference. Grobman et al. Discussed the definition of failed induction of labor, really looking at the latent phase of labor, which is anywhere from a closed cervix up to approximately 4 centimeters for the purpose of this particular research study, but up to 6 centimeters in some of the comparative studies that Grobman et al. Detailed in their research. And it showed that women who had a prolonged latent phase of labor greater than 3 hours had a higher risk of presenting for a primary C-section, primarily due to the increased risk of infection, which can cause chorioamnionitis, which can lead to adverse neonatal outcomes such as sepsis, with the infant ending up in the NICU. And lastly, the systemic review and meta-analysis abstracted charts and did a review across analysis and had similar findings in that there was no increased risk as long as the mother's cervix was favorable. We'll touch on that in the next couple slides. Some of the research strategies that were used, there was 2 specific hosts that were used, the first of which was Wiley Online Library, and the second was Google Scholar. Wiley Online I felt was a little bit more difficult to navigate through. It didn't have the search filters that Google Scholar had, and the majority of the articles were also found on Google Scholar that were found on Wiley, and Wiley did not have access the majority of the time. So Google Scholar was where a lot of the articles were found. It was very easy to use. You could define your criteria according to keywords or year, which was very helpful. The articles were more accessible, and again, easy search filters. And with both of these online web hosts, the keywords that were used were induction of labor, primary C-section, expectant management. Again, the consistent findings were with these 4 research articles by Babu and Mangira, Miller et al., Grobman et al., Wood, Cooper, and Ross. These 5 articles were all fairly similar in their content and findings. Determining the relevance was fairly simple since the topic of the research was listed in the article title. Using Google Scholar simplified the search process as discussed on the previous slide, and each research article had similar findings, with the only real deviation being the sample size and geographic location. So, as we discussed earlier, the research that was performed by Grobman, Babu, Mangira, and Eldon et al. All were conducted through randomized controlled studies of women in diverse settings with both small and large populations. I found this to be interesting because this really helped prove transferability and dependability of the research studies. The research findings were then analyzed and entered into data software and further cross-analyzed with previous studies. Statistical significant findings were similar. The p-value that was often used was the standard deviation of 0.05. So the statistical significant findings were 0.001. And lastly, Grobman also participated in conducting original research on secondary data to determine how obstetricians were defining failed labor of induction, which contributes to C-section rates. This language and this information can be kind of arbitrary, so it's pretty important to study this. And this study was statistically significant in that it showed a correlation between prolonged latent phase of labor and C-section rates. So practice recommendation, a woman who, and this goes back to the Bishop score, and if a cervix is considered favorable, a woman who is planning to undergo induction of labor should really be counseled by the obstetrician if her cervix is not considered favorable. A favorable cervix is one that is soft, usually a fingertip or 1 centimeter. And women who are not first-time moms often will have a higher score on the Bishop scale. Given this score, this will predict how successful a vaginal birth will be, depending on the favorability of the cervix. Therefore, education of the mom is pretty important and would be a part of my practice recommendation.